Okay, so hello everyone. Thank you for having me. My name is Aidan Walsh and I'm one of the final year medical students from the UL School of Medicine. So today I'm going to be presenting a project I did for my final year special study module, and it was Etanercept for Ankylosing Spondylitis, a systematic review. So what I'll do first of all is just introduce the topic, then talk about what the gap in the literature was, the methods for the review, the results I obtained, and the clinical applications of those results. And then I'll finish off just by going through the strengths and limitations of the paper and the conclusions that can be drawn from it. So first of all, what is ankylosing spondylitis? It's a chronic autoimmune rheumatological condition, and it's associated with the HLA-B27 gene. So it's part of the seronegative spondyloarthritis groups of conditions. It can lead to pain and reduce quality of life and inhibit function through axial, so via the spine, or non-axial symptoms. So our typical patient is a young male with a sore, stiff back that gets better with movement and exercise, and it's worse at nighttime and with rest. And usually for mild cases, we can use simple strategies like exercise and analgesia. But for refractory cases, the recommended treatment strategy is these TNF inhibitors. So for those of you who don't know, the tumor necrosis factor is a pro-inflammatory cytokine. So it's driving the inflammation in the background, which is causing the disease. So examples of some of these TNF inhibitors are the MAB drugs, so adalimumab, golimumab, and infliximab, and then etanercept is the one that we were focusing on here. So etanercept itself, it mimics the receptor for tumor necrosis factor, so therefore the TNF is going to go bind to it instead of the actual TNF receptor. So it's inhibiting TNF, basically it's a TNF blocker. So what was the gap in the literature? I was interested in this because I saw a few of these patients in clinic, and I have a background in physiotherapy as well, so I had seen it in physio too. So I went to see what the strength of the literature was for this drug. And what I found was there was no Cochrane review on the subject since 2015. There was also no review of the drug that examined non-radiological outcomes. So the only one available just looked at X-ray findings. And there was no review of RCTs, so randomized control trials. And finally, there was no review involving a thorough critical appraisal. And we know that's pretty much as important as the studies themselves nowadays, is to critically appraise them and see if they're any good. So I felt there was a need to review the latest evidence here to inform best practice. And that led me to 3 simple aims. So I had to systematically search and collect the evidence. I then had to assess the quality of the literature, and I had to summarize best practice in this domain. So once I figured out what the gap was, I went about designing the question, and I used the PICO method. I'm sure you're familiar with for that. So in terms of study design, I chose RCTs only because this hadn't been done so far. I was only able to analyze English language papers, obviously just for logistical reasons. In terms of my participants, I chose those over 16 diagnosed with the AICUR criteria. So that's the Ankylosing Spondylitis International Society, and it's basically the steering group for diagnostic criteria and treatment of ankylosing spondylitis. In terms of intervention, it was Etanercept, both as a monotherapy and a polytherapy. And in terms of comparisons, I was looking at everything else, so pharmacological and non-pharmacological, except for biosimilar products, which were a different domain. And my outcomes, again, were those recommended by ASAS in terms of pain and disability, because previously only imaging findings have been looked at. So I followed the PRISMA guidelines, and on the 10th of August, I searched online databases using the keywords that were involved in my PICO. I expanded these and searched them. I also searched relevant bibliographies and contacted the authors in the field. And then I used the ROB2 tool, which is Cochrane's recommended tool for critical appraisal. And I summarized the results by narrative because there's no meta-analysis available. So I found over 2,500 papers. And after I screened them, removing duplicates and screened them by title and abstract, I was left with 21. And after final review, there were 17 left over. So there were 17 studies included, and the trial durations, there was a large range, so between 6 and 102 weeks. Overall, there was over 2,000 patients, and about a quarter of those were female, aged between 22 and 47. And the disease duration also ranged from 2.5 to 21 years. So we can see that the majority of the studies looked at etanercept versus placebo, and some studies compared it to other therapies, including infliximab, sulfasalazine, and the novel therapy in Asia called an Aidan life therapy. That was just one study. So I went about appraising the studies using the ROB2 tool, and I found that 4 of them were high risk, 4 had some concerns, and 9 were low risk. And most of the concerns were regarding randomization and deviation from treatment groups, as well as reporting of outcomes. So most of the papers used patient-reported outcomes, which obviously could have been influenced by the fact that the patients knew what what drug or what treatment they were getting. So that was the downfall of most papers. But overall, they were high enough quality. And then I looked at what were the clinical implications of these findings. So of the high quality evidence, we know now that Etanercept is superior to placebo in terms of both clinical and serological outcomes, which was something that wasn't really reviewed before. And there's also high quality evidence that it's better than sulfasalazine, which is one of the immunosuppressant drugs. There was moderate quality evidence that it was actually inferior to one of the other monoclonal antibody drugs, infliximab. And there was low quality evidence that it can improve imaging outcomes in terms of MRI and ultrasound findings. Importantly, it was well tolerated and it was flexible in terms of how to give it. So in terms of achieving remission, you can either give the dose weekly or twice weekly. And for maintenance, you can just give 50 milligrams once weekly. And this is good because it means it has a low patient burden. They just need one treatment a week. So in terms of strengths for this study, there were 6 new studies since the last Cochrane review, the subject that I identified. And it was the first systematic review to examine RCT specifically for Etanercept, which I thought was a bit mad considering how common it is in practice. And it also included a thorough critical appraisal section. Unfortunately, the limitations were that there was no meta-analysis, so we couldn't pool the data. There was language bias in that it was only English language papers, and there was selection bias because I was the only reporter involved. And as I said, there was mixed methodological quality and a lack of long-term data. We know it's a lifelong condition. So to conclude, what are the take-home messages from the paper? It concluded that Etanercept was a safe, effective drug for ankylosing spondylitis, and it improved the range of clinical, radiological, and serological outcomes, which was important. It was also flexible in terms of dosage regimes, and it has a low burden in terms of the patient. But the quality of the evidence was mixed with a lack of comparison to other TNF inhibitors. So our areas for future research. Future research should focus on younger demographics because we notice the disease affecting young people. Head-to-head studies versus other TNF inhibitors are needed, and future studies should employ a stronger methodology with better blinding. So thank you all for listening. Here are the references to the papers, and I'd welcome any questions now.